So today we'll be talking about chest X-ray. Now this is chest X-ray, PA view, that is posterior anterior view. It means that X-rays were exposed from the posterior, from the back region, and the X-ray film was with the hold from the anterior or on the chest. So what we can say is uh, today we'll be talking about the lungs, the heart, and the normal structures. Now we know that X-rays are inherently black in color, so we cannot see them. They are black. So whenever lung parenchyma is intact, lung is all filled with air. So X-rays can pass very easily. That is the reason why lungs will be seen as a radiolucent structure. So we must know that this all portion is of lungs. So this is all filled with lungs. That is the reason why you can see the radiolucency over here. So this is all radiolucency of the lungs. Now what we can see is this is the costophrenic angle. Costophrenic angle means this is actually left dome of diaphragm. This is obviously left side. This is right side. So this is basically left dome of diaphragm and this is right dome of the diaphragm. You can very nicely make out these domes of diaphragm. You can very nicely make out that this is the left dome of diaphragm. This is right dome of diaphragm. This is costophrenic angle. This is the rib and this is diaphragm. This is costophrenic angle. The first important thing, you always check this angle, and this angle has to be acute. This angle has to come to here. So there should be radiolucency or blackishness of the lung. So it means that there is no pleural effusion. If there is pleural effusion, this angle will be blocked and this angle will be like this. So if this angle is not blocked, it means that there is no pleural effusion. If this angle is blocked, it means there is pleural effusion. This can be up to any extent up to here as well. So in this X-ray, there is no pleural effusion at all. So we always must check the costophrenic angles. We must check this right dome of diaphragm is always higher to the left dome of diaphragm by around 2 to 3 centimeter. So always make sure that the right diaphragm is more or is at a higher level than left dome of diaphragm. Below this diaphragm, on the right side, what you have is all liver that comes up to this center. This is all liver. And the radiolucency, which you can see here, the blackishness is all part of the stomach air bubble. Stomach air bubbles or stomach air in short. When this is clavicle, this is one of the most important landmark on the chest X-ray. This is clavicle. These are the two clavicles. Most of the time in road traffic accident, you must see clavicle always because clavicle is one of the most common bone which gets fractured into the road traffic accident. So whether to see whether this patient has fracture or not, you must trace the clavicle borders. Just make sure that this clavicle border is smooth. If the clavicle border is smooth, it means that there is no fracture. So just trace it from here to up to acromioclavicular joint or up to this shoulder joint. So here both the clavicles are intact. Clavicle is very important landmark because one of the most important aspects, like the division of the trachea, is below the this sternoclavicular joint. So this is the joint, the clavicle is joining here, and here if you can zoom in and you can see this is basically the division. So if you can appreciate, usually around 3 to 4 centimeter below this joint, you will have a division of trachea into right and left main bronchus. You can simply see that by one more thing. that the spinous process at the level of this at this sternoclavicular joint, you have to come around two spinous process where you'll get the division of the trachea into the two main bronchi. So this is one more important landmark that you have to always see. Uh, you can see the right, this is hilum area. This is hilum area. This is the hilum area because we can very crystal clearly see this pulmonary artery on the right side and as well as on the left side. This is pulmonary artery on the left side. This is pulmonary artery on the right side. These are very important because these are hilar structure. Apart from that, what other structure you need to remember? These are or those things which you must know is the aortic knuckle. So we can very crystal clearly see that this is aorta. This is aorta, which is the largest branch, largest artery of the body, and you can simply trace this aorta here. This is the line which you can clearly see. This is all a line of aorta, whereas the vertebral line, if you can trace, this is here. So this is vertebral line, or this is the central line of these vertebrae, and this is the para-aortic line, which we can very crystal clearly see. Apart from that, this structure which is there is right atrium. What you have is this is a right atrial structure, and this is a left ventricular structure. This is left ventricle. This all is left ventricle, whereas this is right atrial structure. So this is LV, this is RA. Other thing that you must see is the intercostal space. Now we have to make sure that this white reticular linings you can see here, like here, these are the white reticular linings. This all is a part of lung. This is all part of lung. You can see the white dots or lines, fine lines, which are present everywhere, like this, like this, like this. These are all part of normal bronchovascular pattern or bronchovascular markings of the lung. So you can trace this up to most distal part, up to the ribs. It means the lung is present there. So this fine reticular whitish radio opaque fine lines should be traceable up to the rib. If they're traceable up to the rib, it means the lung is present up to here. If there is pneumothorax, it will be simply like you can trace this line up to suppose like here only. If there is pneumothorax, and this all area will be like complete black like this, so that you'll not be able to see any white fine reticular shadows here. It means ki the lung is not present up to here. It means ki there is pneumothorax, there is accumulation of the air, and that air is simply pushing the lung. So in this X-ray it is not there. It means ki pneumothorax is not there. Other things which we need to you must see is these are the spinous processes. This is the trachea. You can see this trachea. This is actually radiolucent or blackish shadow. This trachea is going, and this is the mediastinum. This is all is mediastinum, which is in the center. So it is in the center. When we see these two distances, this is almost equidistant from the same. If there is fibrosis, then suppose if there is fibrosis here, then the mediastinum will be pulled to the same side. So we must know fibrosis pulls the mediastinum to same side. If there is pleural effusion, suppose if there is collection of pleural fluid on this side, this will pull the mediastinum to the opposite side. So mediastinum will shift to the opposite side. So if there is a large pleural effusion, it will push the mediastinum to opposite side, and fibrosis will pull the mediastinum to the same side. I have put so many other videos, you can watch them as well to see what I'm exactly talking about. So in this case, the mediastinum is in the midline. There is no pulling or no pushing. It means there is no pleural effusion. There is no significant fibrosis. Apart from that, other structures which we can see is we always have to see these are the ribs. These are the ribs. These are all posterior ribs. Even though they appear in front, these are actually posterior ribs. And the anterior ribs are like this. These are anterior ribs. What I'm drawing, you can simply see, you can simply make out this line. This is anterior line. This is anterior rib. So you have to see the distance between the intercostal space. So in short, you have to compare this space, this is the rib, this space, this space on the same side and to the opposite side. So you have to compare these spaces to these spaces, and you have to make sure whether they appear almost equal or whether there is significant difference. If it is emphysema, these intercostal distance will be much more. This will appear much ballooned out because emphysema will push the ribs apart from each other. So you have to see these spaces as well. So you have to see these ribs continuity for fractures as well, because in RTA you can get this fractures. So in fractures there will be discontinuity in the bone, or there will be destruction, or there will be incontinuity in the continuation of the bone. So you may get like this only. So there can be fracture here, but here you can very crystally continually see both upper and lower margin. It means that bone is not fractured. So in this X-ray, what we are seeing, the costophrenic angles, the trachea, the tracheal bifurcation, the left ventricle, the right atrial shadow, the clavicle continuation for fractures. So this is overall a normal X-ray which looks like. Thank you.